Hi everyone, welcome back to Next Level Ophthalmology. Last class we have completed the basic anatomy of the optic nerve. Today we will be dealing with the disorders of the optic nerve. So in this topic we will be discussing congenital anomalies, papilledema, optic neuropathies and optic atrophy. Let's begin with congenital disc anomalies. The optic nerve is ectodermal in origin, and the developing fibers of the nerve fiber layer grow into the optic stalk by passing through the fetal fissure around the 6th week of gestation and then pass posteriorly towards the brain. So we know that optic nerve is an extension of the brain. Okay. So what happens is, in congenital anomalies there can be expected developmental anomalies of the eye as well as the brain, because optic nerve is an extension of the brain, and the visual acuity and pupillary reflexes depend on the number of viable nerve fibers that are present in the optic nerve. So based on the abnormal size and abnormal conformation and abnormal tissue, we divide congenital optic disc anomalies into three groups. Okay, so the ones with abnormal size are hypoplasia of the optic nerve and megalopapilla. Hypoplasia signifies that the optic nerve is small in size with less number of viable axons, whereas megalopapilla signifies a large shaped optic disc. Coming to abnormal conformation, the shape and the morphology of the optic nerve is not normal. Here usually it is associated with excavated disc anomalies, in the sense there are excavations within or around the disc. So the diseases here are morning glory syndrome, tilted disc syndrome, optic disc coloboma, optic pit and peripapillary staphyloma. The ones in abnormal tissue are Burgmeister papilla, optic disc drusen and myelinated nerve fibers. So I'll be dealing only with the important ones here. Let's discuss about morning glory syndrome. It is an excavated disc anomaly in which the optic disc resembles the morning glory flower. It's characterized by a large disc with a central tuft of glial tissue, as you can see here, and spoke-like vessels that radiate from the sides or the periphery of the disc. Okay, just like a morning glory flower. The visual acuity is usually poor and it is unilateral, and it's usually associated with mental retardation, transsphenoidal encephalocele, hypertelorism and a depressed nasal bridge. The next is a tilted disc syndrome. This is a fairly common anomaly that is seen. If you can see, the vessels are arriving from the optic nerve in a tilted fashion. So the disc itself is inserted in a tilted fashion so that the superotemporal border is anterior and elevated, whereas the inferonasal border is excavated or more posterior. So along with this, there is this area of the retina, inferonasal retinochoroidal atrophy is there. So as a result, what happens is, when you do a visual field testing in these patients, you will get something like a pituitary tumor. Only thing is, in pituitary tumor you will have a vertical respect, whereas here the field effect will not respect the vertical midline, it will cross the vertical midline. So you will have a bitemporal hemianopia which is not respecting the vertical meridian. The next optic disc anomaly is a optic disc pit. Can you see here? This is usually a round or oval, a crater which is seen within the substance of the disc, and this is the typical location, inferotemporal part, and it's usually associated with a fluid in the macula causing macular detachment. So the visual acuity depends on the status of the macula, and the optic disc per se, the pit per se, would not cause any visual acuity associations. So the treatment in this condition will be vitrectomy with gas tamponade only if there is macular detachment. So let's take a question now. A 1-month-old baby born to young healthy parents is brought to the emergency with seizures. She was found to have hypoglycemia, central diabetes insipidus after thorough investigation. MRI showed empty sella, partial hypoplasia of the corpus callosum and absent septum pellucidum. So which congenital disc anomaly is expected? So if you are an ophthalmologist and if you are called upon to see the fundus, what would you expect? So let's see what the child has. The child is born to a healthy couple and it has hypoglycemia and diabetes insipidus. So probably we are dealing with pituitary anomalies, and the brain shows empty sella, that says that the pituitary has not grown at all, and corpus callosum and septum pellucidum, these are the midline structures in the brain. So this patient has pituitary abnormalities with midline brain anomalies. So this is a typical case of septo-optic dysplasia. This is called as de Morsier syndrome, in which you get pituitary and midline brain anomalies, and it is usually seen in association with optic nerve hypoplasia. So the right answer is optic nerve hypoplasia. There is no logic in this question, it's just a memory based question. So on fundus examination you will see something known as a double ring sign. So if you see carefully here, optic disc, the viable portion of the optic disc, and this is just the empty portion of the optic disc. So you see two rings. So this is known as a double ring sign. So the next question, which of the following is false about optic disc coloboma? So what do you understand from coloboma? Coloboma in Greek means mutilation. Okay, so a part of the tissue has not grown. So let's go back to our fetal fissure, which closes in an inferonasal part by around 6 weeks. So it's not a two-dimensional structure, it is a three-dimensional structure that goes back towards the brain. Okay, so this stalk forms the optic nerve. So this fissure extends throughout the optic stalk. So whenever this closes, it has to close throughout the optic stalk. Okay, so whenever it does not close anteriorly, you get something known as a iris coloboma, and when it does not close posteriorly, you get a optic disc coloboma. Somewhere in between you can get retinochoroidal coloboma. So these are all parts of the same spectrum, and when you get one, you have to look for the others. Suppose I see a patient with iris coloboma, I have to look for retinochoroidal coloboma as well as optic disc coloboma. But when optic disc coloboma is bilateral, you have to think of some syndromic associations. So these are charge. So charge is a mnemonic for choanal atresia, heart anomalies, retinochoroidal disc colobomas, heart anomalies, choanal atresia, renal problems, genital abnormalities and ear abnormalities. So it can be optic disc coloboma can be associated with disc coloboma, it is true. It can be autosomal inheritance, true. It is associated with choanal atresia, might be true. But visual acuity unaffected, not possible. So visual acuity can be affected when significant amount of neurons are damaged. So the correct answer here is D. So this is how a coloboma of the disc appears. So to summarize congenital anomalies of the disc, we have systemic associations only in 3 conditions. The rest of the conditions are sporadic and restricted to the eye alone. So morning glory syndrome is associated with telecanthus, mental retardation and transsphenoidal encephalocele. Optic nerve head hypoplasia is associated with de Morsier syndrome. Optic nerve coloboma is associated with charge syndrome, which I explained just now, and Walker-Warburg syndrome, which is associated with muscle dystrophy, lissencephaly and hydrocephalus. So which of these conditions simulate disc edema? So we are talking of pseudo disc edema. So there are a few congenital disc anomalies that can look like disc edema. So the common condition that causes pseudo disc edema is buried optic drusen. So this is characterized by accumulation of hyaline-like bodies within the optic disc surface. So whenever it is on the surface, it is evident that it is a drusen. When it is buried within the disc substance, it looks like an elevated disc and can confuse as disc edema. So optic nerve coloboma cannot look like a edema because it's an excavated disc anomaly. Same with the other two. These are excavated disc anomalies. So the right answer here is buried optic disc drusen. So this is how it appears when it is on the surface. When it is buried, it looks like an elevated or an edematous disc. So now let's move on to papilledema. It's usually bilateral non-inflammatory edema of the optic disc. So every point in this definition is important. So when you're saying non-inflammatory, you're saying that the optic nerve function is absolutely normal. It is not affected. So why does the disc swell when the optic nerve function is normal? Because of raised intracranial tension. So when there is no raised intracranial tension, you do not call it papilledema, and it's usually bilateral and is usually symmetrical, but we can have asymmetrical cases too. So let's understand what happens in the ventricles. The CSF is continuously produced by the choroid plexus of the lateral ventricles, which then the CSF passes through the foramen of Monro into the third ventricle, and then through the sylvian duct it passes to the fourth ventricle, and then it goes into the subarachnoid space and is absorbed through the arachnoid villi that are present over the surface of the brain. So this is how CSF is formed and then circulated and then absorbed. So what is the connection with optic nerve? So the optic nerve sheath is continuous with the meninges. So there is usually normally axoplasm is being transported in both ways, okay, to the brain and from the brain. So what happens when there is raised intracranial tension? There is a tumor sitting here and it is causing raised intracranial tension and it is obstructing the fluid, that is the CSF. So the normal absorption is not happening and the ventricle starts to swell. As the ventricles and the subarachnoid space are continuous with the optic nerve sheath, there is swelling of the optic nerve sheath which puts pressure on the veins. Okay, so the first thing that happens is the axoplasmic flow is affected. That is what causes papilledema, axoplasmic stasis. Earlier there were many theories for papilledema, but the actual reason for papilledema is stasis of the axoplasm. So let's understand this question now. Which of the following is true about papilledema? The edema is always intracellular. So to begin with, there is axoplasmic stasis within the axons and the axons swell. It is not actual edema, but with time there is extracellular edema as well. So this sentence is false. It is associated with raised intracranial tension. This is true. Edema is due to venous congestion. We just discussed this. The edema is due to axoplasmic stasis. There is a disruption of the neuronal filaments. False, because there is no disruption of the neuronal filaments, they are just swollen. So the correct answer here is papilledema is associated with raised intracranial tension. So this is the mechanism. There is axoplasmic swelling leading to stasis and engorgement of the prelaminar portion of the optic nerve head, causing compression of the small vessels and leading to a hyperemic disc and venous tortuosity. Okay. So what are the symptoms that you get? There are no symptoms. Usually they are minimal. They can have transient obscuration of vision. Okay. Ophthalmoscopy shows filling up of the physiological cup and blurring of the disc margins associated with the enlarged blind spot. In later stages, there is proliferation of the glial tissue that that are present around the axons, leading to deposition of fibrous tissue. Okay, and in late stages there is further loss of axons leading to visual acuity drop. Okay, till in the early stages there is no affection of the optic nerve function. So optic atrophy develops in later stages only. Okay, a 16-year-old girl presents with severe headache for a week associated with projectile vomiting. So this is a typical feature of raised intracranial tension. The other features are neck pain and neck rigidity. Okay, fundoscopy shows early papilledema. So what are the clinical signs? Which of the following signs are features on ocular examination that you expect in this patient? So again, this is just to reiterate that the optic nerve functions like visual acuity, pupillary reflex and color vision remain normal, and here it is very clearly said that it is early papilledema. So the true and the correct answer here is an enlarged blind spot that is seen on visual field analysis. Okay, so what happens is when there is disc edema, it kind of displaces the surrounding retina, and so the photoreceptors are also displaced. As a result, on visual field analysis, you get a blind spot enlargement. So the right answer here is enlarged blind spot on visual field analysis. Visual acuity, pupillary responses and color vision remain normal. All of the following are diagnostic criteria for idiopathic intracranial hypertension except. Okay, so what this is a new term here, IIH. Okay, idiopathic intracranial hypertension. When you say idiopathic, you don't know what the cause is. So this term was earlier known as pseudotumor cerebri, or it was also known as benign intracranial hypertension. There was no tumor or there was no organic cause that was causing intracranial hypertension. So we have a few criteria to diagnose anything as IIH. So it is known as modified Dandy's criteria. Okay, so we have raised intracranial tension evident as papilledema, so this has to be there. There can be abducens nerve palsy, and abducens nerve palsy in raised intracranial tension is a false localizing sign. It occurs due to the compression of the sixth nerve along the petrous apex. So this can be there. Distended ventricles, okay, and raised CSF opening pressures. So the D is also expected. So why don't we have distended verticals? So whenever there is idiopathic intracranial hypertension, we get slit-like ventricles because of compression of the ventricles, not distended ventricles. Okay, distended ventricles are usually seen in conditions like obstructive hydrocephalus. So the answer here is distended ventricles, and this is the modified Dandy's criteria. So there are 6 criteria. There are signs and symptoms of headache, intracranial tension like headache, projectile vomiting. There are no other focal neurological signs excepting abducens nerve palsy. The neuroimaging is normal except partial empty sella. Opening pressure or lumbar puncture shows 250 more than 250 mm of water with normal CSF composition. The patient is alert and awake, and there is no other cause of raised intracranial pressure. So this is the modified Dandy's criteria for idiopathic intracranial hypertension. So it is evident that you have to exclude all causes of raised intracranial tension before labeling a patient as IIH. Next question. All of the following are true about papilledema except, so there is loss of clarity of disc margin. This is true. Presence of venous pulsations, I will discuss this. Elevation of the disc, it is expected, and filling of the cup, it's expected. So the right answer here is venous pulsation. So what happens? Why is venous pulsation lost? So as the retinal vein passes through the optic nerve head and goes back towards the brain, it is present within the optic nerve substance. So whenever there is raise in intracranial tension, there is distension of the optic nerve sheath and there is compression of the vessels. So the pulsations are lost. Normal spontaneous venous pulsations are present in around 90% of eyes, and it is normal. So whenever these pulsations are absent, it is a sure shot indicator of papilledema. So this is the right answer here. Absence of venous pulsation is characteristic of papilledema. Presence of venous pulsation say that it is not papilledema. So what are the signs of papilledema? We can divide them into mechanical and vascular signs. The mechanical signs include elevation of the disc surface, blurred disc margins, and filling up of the physiological cup, and the nerve fiber layer edema along with retinochoroidal folds. Coming to vascular signs, the disc is hyperemic, the vessels on the surface of the disc are engorged, there may be sphincter hemorrhages in the peripapillary area, and there are absence of spontaneous venous pulsations. So whenever the venous pulsations are absent, gentle pressure is applied on the globe to look for spontaneous induced venous pulsations, and these are again absent in papilledema. Okay, we have discussed this as well. This is a revision here. The cause of edema in of the disc due to raised intracranial pressure is increased intracranial tension causes an increased intraocular pressure. That doesn't make sense, so this is wrong. Increased intracranial pressure reduces the axonal transport and thus causes stasis. This is the right answer. Increased intracranial pressure causes a decrease in the arterial supply to the disc causing ischemia. This is wrong again. And increased intracranial pressure causes a decrease in the venous return leading to venous stasis. Again, this is wrong. So the right answer here is B. The papilledema, the disc edema is due to axonal stasis. So now we have discussed in detail papilledema, but there are conditions in which there is disc edema and associated optic nerve function loss. So these conditions are known as optic neuropathies. So loosely we can use the term papillitis in the sense inflammation of the papilla or the optic nerve head. So the etiology in papilledema is raised intracranial tension, and it is a passive edema. It is not an active edema, whereas papillitis refers to an inflammatory cause of disc edema. Papilledema is usually bilateral because there is a central cause for it, whereas papillitis is usually unilateral. Then symptoms, there is headache, vomiting, and transient obscuration of vision in papilledema. Diplopia can be there due to a false localizing sixth nerve palsy. In papillitis, there is rapid loss of vision in one eye and maybe associated eye movements are painful. The signs, usually no other signs are there, no focal neurological lesions, but if there is a tumor or something that's compressing, there can be focal neurological deficits. In papillitis, there is decreased visual acuity, dyschromatopsia, color desaturation, RAPD, and visual field defects because it is an optic neuropathy. Fundus is usually the media is clear. Disc is elevated to around 6 diopters. Here the disc elevation is not as much, and venous dilatation and engorgement is much more in papilledema when compared to papillitis. So these differences help you to understand whether the underlying cause is a raised intracranial tension or it is a optic neuropathy. So a 22-year-old girl is brought to you with severe headache and vomiting. The fundus examination reveals a hyperemic disc with blurred nasal margins. How do you clinically confirm the diagnosis of early papilledema? So you have all the features here, symptoms here, and there are very subtle signs. So the answer here is, let's try one by one. Apply pressure on the globe and look for venous pulsations. Yes, we have discussed about this right now. Wait for 2 weeks and review the patient. It doesn't make sense. You don't have to wait. It's an emergent condition. Check intraocular pressure. Rise in intraocular pressure won't give you a diagnosis of papilledema, and do a lumbar puncture. Such an invasive procedure is not required at this stage just to confirm the diagnosis of papilledema. It may be done to confirm the etiology of papilledema, but not just the diagnosis. So the answer here is A. Patent's lines are linear horizontal lines on the retina. No. Linear lines are usually seen when there is a tumor in the retrobulbar portion. and it's indenting the globe from posteriorly. Vertical lines, no. Circumpapillary retinochoroidal folds, these are the patent lines that you are usually seeing in papilledema. So if this is the disc here, you will see circumferential folds on the retina, and they are usually associated with papilledema. Branching lines in the choroid, no. So the right answer here is circumpapillary retinochoroidal folds. A 5-month-old child is admitted to the pediatric ICU and you are called upon to diagnose papilledema as the child has other features suggestive of raised intracranial tension. So whenever a child has raised intracranial tension, a common ocular finding you see is sunset sign, in which the lids are retracted and the eyeball is looking down. Okay, which of these is a reason for the appearance of papilledema in later course of the disease? So whenever there is a raise in intracranial tension, it doesn't reflect on the optic nerve head as in adults. So this is what is the reasons for this? Infants have a fewer axons in the optic nerve and thus do not cause papilledema soon. So this doesn't make sense. The child is always born with the number of axons. Axons do not replicate with time. This is not true. The brain is smaller than the cranial cavity, so there is more space in the subarachnoid space. No, this doesn't make sense either. The growth of the skull is stimulated by the growth of the brain. So it's not like there is more space and the brain grows later. So this doesn't make sense. The fontanelles are not yet fused, so elevated fontanelles can accommodate a slight rise in pressure. This is true. So this is a 5-month-old child and the anterior fontanelle closes only after 18 months. So whenever there is a raised in intracranial tension, you can see or feel the fontanelles and understand the nature of the intracranial tension. Papilledema cannot be assessed in such a small child as pupils are smaller. No, you can always dilate the pupils with drugs and then see the fundus. So the right answer here is the fontanelles are not yet fused, and so the papilledema cannot be present early in the course of the disease. Which of these drugs is not known to cause idiopathic intracranial hypertension? So you should know that there are a few drugs that can cause idiopathic intracranial hypertension. It's usually seen in females and who are fertile and usually in their 40s. Okay, so the last point may not be true. You can see it even in 20s, 30s. So it's usually common in ladies and who are in their fertile age group. And there are a few drugs that are known to cause idiopathic intracranial hypertension. They are vitamin A, vitamin D, corticosteroids, tetracyclines and nalidixic acid. So vitamin B is not known to cause idiopathic intracranial hypertension. So there is no logic, it's just a memory based question. The right answer here is vitamin B. Which of the following neurological deficit is accepted for the diagnosis of IIH? Again, we go back to Dandy's criteria, which says absence of neurological deficit is a criteria for IIH excepting abducens palsy. Abducens palsy again is a false localizing sign and is seen due to raised intracranial tension causing compression of the 6th cranial nerve across the petrous apex. So the right answer here is abducens palsy. So grading of papilledema is done by Hugh and Jacqueline classification, which says early, established, chronic and atrophic. What are the characteristics of early disc edema? There is just obscuration of the disc margins, usually goes in the following order: supranasal, infranasal and finally temporal. The reasons for this I have discussed in the first class. Absence of spontaneous venous pulsations, hyperemia of the disc and peripapillary sphincter hemorrhages. In the established stage, all the margins are involved and the disc is well elevated. The cup is filled with blurred margins. The veins become tortuous and engorged with presence of hemorrhages, and you see patent lines. You can also see cotton wool spots and hard exudates at the macula. In chronic papilledema, there is some amount of pallor is already setting in. Visual acuity starts reducing. There are no active signs like hemorrhages or cotton wool spots, but you see some champagne cork-like appearance with crystalline drusen deposits on the surface known as corpora amylacea. This is amyloid deposits on the surface of the disc. So this is characteristic of chronic papilledema. Then last one is atrophic papilledema, where you see a pale disc with blurred margins, and you see these watermarks here, which are suggestive of receding edema. So these are watermarks or that resembles, that points towards a old disc edema. So what are the investigations you would like to do when you see papilledema? Papilledema, the cause is neurological, so neuroimaging should be the first. But in ocular investigations, you do a visual field analysis that shows a enlarged blind spot. OCT and FFA help in only confirming that there is papilledema. So let us learn about the blind spot. The blind spot lies in the temporal aspect of the field. It is separated from the fixation on the macula by around 5 to 7 degrees and extends about 12 degrees. Enlarged blind spot is diagnosed when the dimensions are more than what we have mentioned here, and it's characteristic of papilledema. Treatment is mainly aimed at reducing the intracranial tension by removing the offending cause. So whatever the cause is it cerebral edema, is it meningitis, is it intracranial space occupying lesion? So all these have to be treatment. There is no ocular treatment per se, but when the cause is not there, in IIH we need to give them drugs that decrease the intracranial tension in the form of acetazolamide, repeated lumbar punctures, and ventriculoperitoneal shunts and stents. So once there is optic atrophy, there is no treatment or there is no comeback from this. So let us now deal with optic neuropathies. These are conditions that are characterized by dysfunction of the optic nerve due to various etiologies. There is dearrangement of the optic nerve function tests, and depending on what they are, we can, seeing the clinical profile, we can identify the underlying etiology. So the causes are inflammatory, ischemic, para-infectious, traumatic, compressive, infiltrative, hereditary, and toxic and nutritional. I'll be dealing only with the important ones here. Inflammatory optic neuropathies is characterized by the inflammation and demyelination of the optic nerve that can be associated usually with autoimmune disorders. The most common autoimmune disorder that we are dealing with here is multiple sclerosis. It is visible as a papillitis, or there can be optic disc edema with macular star, or the disc may appear completely normal as in retrobulbar neuritis. The term optic neuritis is usually referred for inflammatory optic neuropathy associated with demyelination. Okay, whenever we see a macular star, the diagnosis goes more in favor of a infectious etiology, and this is known as neuroretinitis. Okay, so it can have a normal looking fundus, an edematous disc, or a neuroretinitis, edema of the disc along with macular star. So all of the following are associated with optic neuritis except painful visual loss, normal pupillary reaction, Pulfric phenomenon, and Uthoff phenomenon. So here when someone says optic neuritis, it should occur to you that we are dealing with multiple sclerosis associated inflammatory optic neuropathies. So a typical attack of optic neuritis in multiple sclerosis is usually seen in women, and they are usually younger, 20 to 40 years of age, and there is painful ocular movements because of the inflammation of the sheath of the optic nerve, which is very close to the muscles, mainly the medial rectus. So there is painful ocular movements, and the vision loss is rapid and profound. The visual loss may be as bad as perception of light, and there is always associated RAPD or afferent pupillary defect. You cannot have an inflammation of the optic nerve with normal pupillary reaction. So what is the third option here? Pulfric phenomenon. Pulfric phenomenon is a condition in which any rotatory movement is perceived by the eye as a straight movement. This happens due to a conduction delay that happens between the two eyes. Okay, so this is also known as poor man's VEP. And Uthoff's phenomenon is known as is characterized by flashes of decrease in vision when there is raise in the temperature of the body. Okay, so the next other common symptom that is seen in optic neuritis is phosphenes. Phosphenes are flashes of light that are seen when there is mild stimulation of the eye. So the correct answer here is normal pupillary reactions, because an attack of optic neuritis is always characterized by RAPD. The rest are always, most of the time, they are present. So this is how color desaturation looks. The color may look a little dull. They may not say complete loss of color, but one eye, the red appears less red than the other eye. Which charts are most useful in multiple sclerosis trials? The answer is Sloan chart. There is no logic here. Sloan chart is low resolution or low contrast charts that are useful in picking up optic neuropathies, because usually there is color desaturation associated with MS. Pelly-Robson chart is usually used for contrast sensitivity. Snellen's chart is used for visual acuity testing, and ETDRS charts uses logMAR for visual acuity testing and is usually reserved for diabetic retinopathy evaluation. So the right answer here is Sloan chart. A multi-center treatment trial was conducted by the National Eye Institute in the USA called the Optic Neuritis Treatment Trial. So ONTT is a landmark study that all of us should know about. What happened in this? This study included all patients with acute attack of optic neuritis, usually females, 18 to 46 years of age, visual loss within 1 week duration, and not on any steroids or any medications. So what did they do? All these groups were randomly divided into 3 groups. One was the placebo, when they did not receive any treatment. The second group was intravenous group, in which they received methylprednisolone 1 gram per day for 3 days, followed by 13 days of oral steroid and a short taper. And the third was a oral steroid group. So what they found in this study was that visual recovered in all 3 cases. It's not like treatment was causing any change in visual recovery, but in the group of intravenous steroids, the visual recovery was faster and the number of recurrences were lesser. In the oral group, the number of recurrences were more than what in placebo group. So oral steroids is a complete no-no. You have to give intravenous steroids. This treatment protocol is still being followed and holds good for MS related optic neuropathies. So now let's see the question. Which of the following is false about the results of the trial? The study included optic neuritis with visual symptoms less than 8 days duration. Right? True. So this is true. Optic neuritis is associated with significant recurrences when treated with oral steroids. This is also true. Intravenous methylprednisolone followed by oral steroids will cause permanent cure. This is false. We still get recurrences, but the rate of recurrence is lesser in this group. Initial intravenous methylprednisolone followed by oral steroids will delay conversion into clinical multiple sclerosis. This is true. So the right answer here is C. Which of the following differentiates ischemic from optic neuritis? So ischemic optic neuropathy, again it is an optic neuropathy. It is characterized by deranged optic nerve function. So there is decreased visual acuity, there is RAPD, there is decreased color vision, and there are field defects. So how do you differentiate that from optic neuritis, which also has all these things? So the type of field defect that you see in optic neuritis is a little different from what you see in ischemic optic neuropathy. The type of defect that you see in optic neuritis is central or centrocecal, whereas in ischemic it is usually altitudinal. So the field effect differentiates between an ischemic and an inflammatory type of optic neuropathy. So what are the salient differences between AION and optic neuritis, as both can present with decreased vision, both can present with disc edema. So AION or ischemic is usually seen after 50 years of age and there is no gender predilection, whereas in optic neuritis there is a female preponderance and more in 3rd to 4th decade of life. Visual loss is sudden in both, but it may or may not be associated with jaw claudication in AION. Here the pain is more on extraocular movements. The type of edema that you see in AION is pallid disc edema or sectoral disc edema, and retrobulbar neuritis is far more common in optic neuritis. So in ischemic, you get an altitudinal field effect which is pathognomonic of ischemic optic neuropathy, whereas you get a central or a centrocecal scrotoma in inflammatory optic neuropathies. Let's take a question now. A 16-year-old boy presents with unilateral painless loss of vision in the right eye for 3 days. So there is a painless loss. It's a unilateral condition and it is a 16-year-old boy. So all these are not favoring MS where we had women. Okay. On examination, the visual acuity is 660 in the right eye and the left eye 66. There is an RAPD with the fundus showing disc edema with hard exudates arranged in the form of a star. So what is the morphological diagnosis here? The morphological diagnosis is neuroretinitis or optic disc edema with a macular star. Also there is some history of fever with preauricular lymphadenopathy. So again we are getting a hint towards a probable infective etiology. The visual acuity remained the same even after 2 weeks. So what did we learn from multiple sclerosis? It is a self-limiting attack. The visual acuity usually recovers by itself even if we give a placebo. So let's look at the options now. You are thinking of multiple sclerosis? No. So you don't need an MRI here. ELISA for Bartonella? Yes, more probable. Lumbar puncture for NMO antibodies. NMO is neuromyelitis optica, which is again a cause of demyelinating optic neuropathy. So the presence of fever, preauricular lymphadenopathy, presence of a macular star does not go in favor of a neuromyelitis optica. Again, you don't need lumbar puncture. Skin biopsy to rule out autoimmune optic neuritis? No, because the morphological diagnosis is going more in favor of a infective etiology. So the right answer here is ELISA for Bartonella Hensley, which is diagnostic for cat scratch disease. So cat scratch disease is characterized by fever, preauricular lymphadenopathy and usually responds very well to doxycycline. It is not a common disease in India. It is common in the West. So let's come to this diagram again to understand ischemic optic neuropathy. The vascular supply of the optic nerve is through the ophthalmic artery, from which you have a lot of pial plexus arising, and then from the ophthalmic artery a branch of central retinal artery pierces the dura at least 1 centimeter behind the globe. Okay, and the rest of the ophthalmic artery gives rise to the short posterior ciliary arteries in the form of a superior and an inferior trunk, which then form anastomosis around the optic nerve to form the circle of Zinn-Haller. So the area of AION is this circle of Zinn-Haller, because in this area if you get ischemia there is always disc edema, whereas before the entry of the short posterior ciliary arteries and central retinal artery you have the area of PION or the posterior ischemic optic neuropathy. What is the reason for an altitudinal field effect in anterior ischemic optic neuropathy? If you remember the drawing we just discussed, we saw that there was a superior and an inferior trunk of the superior short posterior ciliary vessels that supply the optic nerve head. So the optic nerve head is supplied by the ciliary circulation and not the retinal circulation, and this has to be remembered. The central retinal artery divides into an upper and a lower half before supplying the retina. Okay, this does not have anything to do with the optic nerve head circulation. The superior and inferior posterior ciliary artery arises from the ophthalmic artery. This is true. Individuals have only one half, superior or inferior half, well perfused. So during ischemia, one half becomes affected. This cannot be true. So the right answer here is superior and inferior posterior ciliary artery arising from the ophthalmic artery that supplies the optic nerve head in a vertical fashion. That's why you get an altitudinal scotoma in which either the superior or the inferior posterior ciliary artery is affected. If the superior is affected, you get a superior altitudinal hemianopia, and if inferior is affected, you get an inferior altitudinal scotoma. So in ischemic, we have two main variants. One is arthritic, the other is non-arthritic. So what does the word arthritis mean to you? It is associated with some form of inflammation, and the disease here is giant cell arthritis. It's usually seen more in women and in an elderly age group, and there is occlusion of the arteries due to inflammation. So the inflammation is quite severe and the visual loss is also quite profound. So there is transient episodes of transient loss of vision which may come before the visual loss, and it might be associated with CRAO as well. The visual loss is usually very bad and the other eye can be involved in a very high percentage of people. There can be diplopia due to ischemia of the extraocular muscles, and there are some common visual phenomena like bright light induced amaurosis. In the sense, it is something like claudication of the retina. When the retina is bombarded with a very bright light, the photoreceptors do not get enough oxygen through reduced blood supply. That's why they develop something known as bright light amaurosis. This is very, very characteristic of giant cell arthritis. They may also develop jaw claudication. In the sense, after chewing for a while, they feel tired in the jaw, and scalp tenderness may be there because of the inflammation of the temporal artery. There can be severe one-sided headache with polymyalgia rheumatica. Let us think about what is happening on the non-arthritic side. It is usually seen in the 5th to 6th decade with no gender predilection. We still don't know what the cause of ischemia here is, but there are a few associations like uncontrolled diabetes, uncontrolled attack of an angle closure glaucoma, hypertension, massive loss of blood, perioperative loss of blood, and some drugs that cause smooth muscle relaxations like sildenafil. Visual acuity loss is not as bad as in arthritic, and other eye involvement is not so common. So when you get an NAION or non-arthritic ischemic optic neuropathy in a younger individual, always rule out disc drusen, because this is a predisposing factor to develop non-arthritic ischemic optic neuropathy. The other features you can see is a small crowded disc which is usually seen in the other eye, because the eye that you are seeing now is edematous. So what is the appearance of the disc? In arthritic, you see a pallid disc edema and there might be cotton wool spots indicating presence of ischemia. In non-arthritic, the edema is usually sectoral and hyperemia may be present. The other eye has a small or a no cup, what we describe as a crowded disc. FFA shows delayed choroidal filling and disc filling. Here in non-arthritic, only disc filling delay is present. So ESR and CRP are inflammatory markers that are very high in arthritic, where they are normal in non-arthritic, and there are no specific blood tests that can help us to identify the cause. Treatment here is very high doses of corticosteroids, and there is no proper treatment. FDA approved treatment still remains absent in non-arthritic ischemic optic neuropathy. So let's take a case based on this discussion now. A 73-year-old woman, it's a typical case of an elderly lady presenting with pain during chewing. So we have jaw claudication for the past 4 days and there was no dental pathology found. Presently she has complaints of sudden painful loss of vision on the same side as the jaw pain. On examination, the visual acuity is very low. 20 by 200 is around 6 by 60 and there is an RAPD. So visual field examination shows a altitudinal scotoma. So one thing you should remember is altitudinal scotoma can happen in both arthritic and non-arthritic. If you see, the superior half of the field is gone. So this is a superior altitudinal scotoma. So what is false about this disease? So what are we dealing with here? The diagnosis here is arthritic anterior ischemic optic neuropathy. What do we expect here? There is expected pallid disc edema. So this is true. It is a self-limiting condition? Not at all. It cannot be a self-limiting condition because it's an inflammatory condition. We have to treat it with steroids. May affect the other eyes? Yes. It is associated with giant cell arthritis? True. So the right answer here is a self-limiting. It is not a self-limiting condition and you need to act urgently. It is a neuro-ophthalmic emergency. So this is how a pallid disc edema looks. The disc is elevated and it's very pale. So the next question, which of the following is not a warning sign of arthritic anterior ischemic optic neuropathy attack? So we have discussed this. Jaw claudication, yes. Can be one-sided headache, yes. Bright light induced amaurosis, yes. Central artery, retinal artery pulsations, no. So this is the right answer here. Where do you get central artery pulsation? Central retinal artery starts pulsating when the intraocular pressure is more than 50 to 60 mm of Hg, usually seen in very high glaucoma. Let's have a small word about the posterior ischemic optic neuropathy. So here the site of occlusion is much posterior, as I showed you in the previous image. It resembles AION in the symptoms. However, on disc examination you see that there is no disc edema at all. There is sudden painless loss of vision in one eye, RAPD is there, and you cannot have a proper field effect. It might be altitudinal. The disc undergoes atrophy by around 6 weeks and shows cupping resembling a normal tension glaucoma. So this is a differential diagnosis for normal tension glaucoma. This is also known as shock optic neuropathy as it develops in a setting of severe hypotension. It can be also seen in spine surgeries because the patient is in a prone position for very long time. Let's move on to toxic and nutritional optic neuropathy. Why have I kept both together? Because they both have similar presentation, similar site of affection, and they were previously referred to as toxic amblyopia. This is not an amblyopia, it's a misnomer. We have to call it toxic optic neuropathy. It's usually chronic and usually bilaterally symmetrical, and the type of optic atrophy you see is primary because you do not get any disc swelling. It usually has a retrobulbar neuritis. The damage is seen in the papillomacular bundle leading to temporal disc pallor, which we had discussed in the first class. The common causes for toxic amblyopia are methanol poisoning, tobacco amblyopia, and ethambutol toxicity. In tobacco alcohol amblyopia, the toxic agents are cyanide and alcohol. The treatment is cessation of smoke and alcohol, hydroxycobalamin given monthly along with thiamine and folate. The visual recovery is usually very slow. Methanol poisoning is more dramatic and alarming because the visual recovery is very poor. The toxic agents implicated here are formaldehyde and formic acid. Treatment is urgent gastric lavage with intravenous bicarbonate to combat the systemic acidosis, and ethanol is given to remove methanol from getting converted into formaldehyde by the same enzymes, and peritoneal dialysis to remove excess methanol. In ethambutol toxicity, usually seen in patients who are taking ATT or anti-tubercular therapy. Ethambutol is the toxic agent, and cessation of ethambutol with the hope that the eye recovers is the treatment of choice. Let's take a question now. A 21-year-old garage worker was rushed to the emergency with a history of suicidal attempt. The patient is still conscious but confused and is continuously vomiting. He has a characteristic formaldehyde breath and complaints of severe abdominal pain. So they have given a diagnosis of methanol poisoning, but even in absence of this, you should be able to get the diagnosis because they have given two good hints here: formaldehyde and abdominal pain. There is systemic acidosis. So what do you expect in the fundus after 2 weeks? Actually, if you catch the patient then and there and see the fundus, you might see disc edema, and the disc may be normal also, but they are specifically telling after 2 weeks. So the rate at which the optic disc goes into atrophy is very fast here because there is severe acidosis, and the formaldehyde is injurious to the papillomacular bundle and the ganglion cells. So after 2 weeks, if you see, you will get primary optic atrophy. A 60-year-old chronic smoker who underwent gastric resection 1 year back presents with blurred vision. So what are the clues here? He's a smoker, so you have smoking. Gastric resection points towards B12 deficiency. Presents with blurred vision. On examination, his visual acuity is 6/18 in both eyes. There was no improvement with pinhole. Color vision was very bad, as they say that he could read only one test card on Ishihara's chart. Fundus reveals temporal pallor of optic disc. His serum vitamin B12 was found to be 70. So they have given all the points here for you to diagnose nutritional optic neuropathy. So what we have learned so far: nutritional deficit, nutritional optic neuropathies usually damage the papillomacular bundle. So the expected disc changes are temporal pallor of the disc, and on field analysis you see centrocecal scotoma. There should be no confusion about this I think I've repeated 3 times already. Alright, so the answer here is centrocecal scotoma. Next is compressive optic neuropathy. There are various causes like dysthyroid optic neuropathy associated with thyroid eye disease. Various tumors of the optic nerve sheath present within the retrobulbar space can cause compressive optic neuropathy. Which of the following tumors is associated with optociliary shunts? So what are optociliary shunts? These are collaterals that develop between the retinal circulation and the ciliary circulation. They are usually seen rising from the center of the disc and going to the periphery of the disc. So these are well formed vessels and it takes time. So if the collaterals have to develop, that means the disease has been present for a long time. So it is supposed to be a slow growing tumor. Glioma is usually associated with optic atrophy. Okay. There is no optic nerve lymphoma. Optic nerve melanocytoma is a disc presentation and is seen as a blackish discoloration seen on the disc surface. So the right answer here is optic nerve sheath meningioma, and it's usually associated with opticociliary shunts that may be also associated with optic atrophy. So this is how opticociliary shunts look. Okay, next, coming to traumatic optic neuropathy. It is an important cause of permanent visual loss, occurs at around in 50% of patients. The visual acuity may be as low as perception of light only. The visual acuity may be 6/6, it may be 660 or PL negative. So you cannot say based on how the eye looks. So the visual acuity ranges from 6/6 to PL negative. It can be a direct injury to the optic nerve or due to a blow to the frontal area of the head, severe enough to cause loss of consciousness. The shearing forces of the movement of the brain cause movement of the intracanalicular portion of the optic nerve. So there is a shearing pull on the pile vessels which lead to a loss of blood supply to the intracanalicular portion and thus resulting optic neuropathy. So here the take home points are: there is optic neuropathy associated with trauma. So there is a decreased vision, decreased color vision, a field loss and a pupillary defect characterized by, associated with trauma to the optic nerve, which may be associated with a head injury. Let's go back this beautiful drawing here. So how does the site of affection of trauma lead to the fundus features? So if the trauma is here, you get optic nerve head avulsion. If the trauma is in this region, you get a CRAO like presentation. and more commonly if the trauma is here, you get a normal fundus at the presentation. So the only clue here you will have is decreased visual acuity with loss of pupillary reflexes. A 16-year-old boy presents to the emergency with blunt trauma over the right eyebrow during a vehicular accident. He is conscious and complains of blurred vision. So you have some subjective complaints here. On examination, visual acuity is 612 and there is RAPD and a normal fundus. So you know that there has been some sort of traumatic optic neuropathy by now. So what is the treatment of choice? Remember, there is no proper FDA approved treatment for traumatic optic neuropathy. We just follow the ONTT trial. In the sense, we give 3 days of intravenous methylprednisolone followed by a 13 days of oral prednisolone by a short taper. No treatment is required in visual acuity is good, so we cannot just not care about it. We have to give a trial of steroids. With an RAPD and a small deficit in visual acuity might improve with some steroids. Okay, a CT scan is always performed in optic neuropathy, traumatic optic neuropathy, to rule out if there are any impinging fracture segments present within the orbit. So the option C here, this was used in Naski's trial. It is for spinal cord injuries and very high doses of steroids are given, and it is found to help in spinal cord injury with not much result in the optic nerve injury. Okay, so oral prednisolone, okay, this is also not advocated, this is also not approved. So what we follow here is the ONTT trial. So the right answer here is B. Hereditary optic neuropathies, mainly there are two types, Leber's and autosomal. Leber's is an X-linked mitochondrial gene mutation associated optic neuropathy, and it affects males more because it is a mother to son inheritance. The visual acuity drop usually is seen in the third decade and associated with the central visual loss, may be asymmetric, whereas autosomal recessive is usually autosomal recessive and dominant are usually seen in both males and females, and the visual loss is quite bad and starts within the first decade of life. So there is a short period of pseudo papilledema, in the sense there are lot of telangiectatic vessels on the disc surface, which is very characteristic of LHON, and this is followed by temporal pallor. So there are no such pseudo papilledema that you see in autosomal hereditary optic neuropathies, and there is development of pallor. There are no systemic associations in LHON, whereas in hereditary optic neuropathies you get a Didmode syndrome characterized by diabetes insipidus, diabetes mellitus, optic atrophy and deafness, also known as Wolfram syndrome, and there can be Charcot-Marie-Tooth syndrome, in which you get optic atrophy with polyneuropathy. There are no effective treatment for both conditions. However, ibetanone has been tried for LHON with variable success. Now let's deal with the last topic for the day, optic atrophy. So it is an end result of any optic neuropathy characterized by loss of axons and loss of blood supply to the optic nerve head. So the pallor can grade from just subtle pallor to chalky white pallor. It can affect the whole disc or it can be segmental. So these patterns help us to understand the probable underlying etiology. It is usually accompanied by deranged optic nerve function tests like decreased visual acuity and disc chromatopsia. Based on how the disc looks, you may have 4 types. Primary optic atrophy is characterized by diffuse chalky white pallor of the disc with clear margins, normal cup and normal vessels. So the causes are usually proximal compression of the optic nerve due to tumors, Leber's hereditary optic neuropathy, traumatic optic neuropathy, toxic amblyopias and tapes dorsalis. So this is how primary optic atrophy looks, with clear cut margins, normal cup and normal blood vessels. Secondary optic atrophy on the other hand is characterized by dirty white appearance of the optic disc with sheathing of vessels. It usually follows a swollen disc. It can be either following papillitis or papilledema. So if you see carefully, there is some sheathing of vessels that you see here. Consecutive optic atrophy is secondary to inflammation or the degenerative process. in the retina or choroid. So the common causes are retinitis pigmentosa, diffuse chorioretinitis, and pathological myopia. And the disc here is described as waxy pale. The last type is glaucomatous optic atrophy, characterized by all features of glaucoma such as a deep cup, bayoneting sign, nasalization of vessels, and laminar dot sign. So what type of optic atrophy do you see in long-standing retinal detachment? We just discussed this. The answer is consecutive optic atrophy. The appearance of pallor of the optic disc in optic atrophy is due to a decrease in the number of blood vessels. That is true. So what happens is, during inflammatory process or any process, there is a decrease in the surface blood supply of the optic disc. There is gliosis of the nerve, yes, because there is neuroglial proliferation leading to fibrosis and glial deposition. There is a decrease in the number of axons, true. So the answer here is all of the above. In optic atrophy, you get a decrease in the number of axons, gliosis of the nerve, and also a decrease in the number of blood vessels. So that's all for today. We'll meet you next week for visual pathway lesions. Hope you had a nice class. Thank you.